she coughed. She removed the sputum that had blood stains. And it was at night, so I couldn't sleep the whole night.
Pia hii ni TB. Na Joyce alikuwa mwelevu sana. Joyce alilia, akakataa, akasema no, me have got no TB.
My mom said no, nobody in our family has ever suffered tuberculosis. She told me, now I'm not going to stay with you. Pack your things and go.
Despite studies showing that tuberculosis has been around for centuries, it still remains one of the top leading causes of death on the planet. TB is a contagious infectious disease which is spread from one person to the other through air droplets when one coughs, sings, or sneezes. Simply put, as long as you are alive and breathing, you are at risk of TB. This is not just the story of TB cure and prevention, but also the story of collaboration and partnerships with other stakeholders in the fight to significantly reduce Kenya's TB burden. Listed among the 30 high-burden countries with TB globally, Kenya is estimated to lose the equivalent of a busload of people to TB every day.
TBAC as a project was funded from 2013 and has been running till 2018. We'll be closing out in November of 2018. This funding was to support the national level response to TB in Kenya. And the premise of the funding was really to support what was already seen by trends in terms of case numbers, a decline in the number of cases of TB in Kenya. And that was the premise really. Our role was to accelerate that decline towards much lower levels of TB, towards elimination of TB in Kenya.
Before 2011, healthcare workers relied on the use of microscopes to detect the presence of TB bacteria in the samples they collected from patients. This investigative approach, despite being simple and inexpensive, usually led to missing of several TB cases and was only reliable for pulmonary TB cases. In February 2014, Tuberculosis Accelerated Response and Care supported Kenya's Ministry of Health and systems surrounding a diagnostic technology that is highly sensitive to the TB-causing bacteria called GeneXpert. This innovation led to an increase in the number of TB cases identified, which were previously missed, ensuring that more Kenyans received correct diagnosis and treatment for TB.
With the increased sensitivity of positive results, automatically, if a patient is positive with GeneXpert, the patient is positive. Basically, because it has with genome testing, there's no doubt about getting DNA, an actual DNA identified and taken to be the actual DNA of TB, as opposed to having a microscopy.
The GeneXpert machines, they do use modems because there is what we call GX limbs. It relays the results through emails to the clinicians who made requests, because they are the people sitting with the patients. Then samples are sent to the reference lab, the central lab. Then as they do, when the sample has run, it automatically relays the message and also the emails to the clinicians.
The number of tests that have been done through GeneXpert has increased over time, and we've actually seen an increase in the number of bacteriologically confirmed TB, but in addition also of drug-resistant TB through GeneXpert expansion. This will continue, and the hope is that every patient can access a GeneXpert test in Kenya.
Through the enhancement of TB-Cash, we have had a faster turnaround time for meetings and supervision payments, as well as patient social support travel to health facilities for monitoring and receiving drugs. The timely transfer of funds to facilitate county and sub-county TB coordinators has ensured continued support for quality TB services at all levels.
Through TBAC support, we we supported phase 3 development, which included enhancing of the system, making it more user-friendly, and also creating platforms for more data synthesis. And in addition, we also supported ensuring that that data that already is in the TB system that was accessible mostly to NTP program is then linked to the DHIS2. So DHIS2 is the platform that the Ministry of Health in general uses for all its data. So that now there's data that is pushed to DHIS2 from TB. So we now know, at a national level, accessible to anyone, you can access the TB data in DHIS2.
So TB is not only a data collection tool, it's also a program management tool. So through that system that was supported and fully funded by USAID, we have also a finance management system. So this has helped us with accountability in the program, and also for healthcare workers and people who receive money through that system. For example, as I mentioned, we have the patients receiving 6,000 a month. Getting someone to go on the ground to pay those patients cash is a big problem. But if we use M-Pesa, patients are able to get their money all the time. What that means is we have reduced loss of funds. We're able to tell who got and who didn't get.
Since TB cash came in, life became easy because the nurse has got transport to go and inject the patient at home. We have got 5 patients who are on DRTB. All of them are getting their social support through TB cash. They get monthly.
Every month they was giving me money in the telephone through M-Pesa, and that 7 months I was taking this medicine, I was taking the money.
When we go for our support supervision, provided that you have done the number that they have said, they do pay. This is also a motivating factor as it facilitates our movements easily. We go to the field, we do the TB work comfortably.
In order to sustain the delivery of quality TB care to patients, TB ARC, in collaboration with the NTLD-Program, was involved in the capacity building of different cadres of personnel through different approaches. To be able to trace the missing cases, the county coordinators had to undergo union training so as to capacity build them to understand how to interrogate their data and be able to break down to what is needed at the facility level.
The keynote of the union trainings with CHS revolves around this method called TB Data for Action. And it sounds very simple. It's a new way of looking at the routinely collected data that TB county and sub-county coordinators have collected for years and moved upward to the NTP for their reporting. What has been exciting is that when we have done the field work in the training programs, all of a sudden you see the county coordinators' faces light up.
The top management of the organization, the chief of party, Dr. Brenda, decided that instead of taking few people to international training, which is a little bit costly, why don't we bring it to Kenya so that we train more people, more healthcare workers who are in need of this training.
Union training taught us that whatever we are generating can tell us what we are doing, how much we are doing, and how well we are doing. We were also taught about coming to the same facilities and make sure that the people they diagnose to have tuberculosis, they get the best treatment and they get the best outcome.
Partnerships were formed with international as well as local organizations such as the International Union Against TB and Lung Disease and Médecins Sans Frontières to deliver special trainings. Infrastructure support towards Project ECHO, an online teleconferencing technology, was also supported for cross-learning amongst TB professionals in Kenya, with several people logging into the weekly sessions from various locations around the country.
ECHO is it's called Extension for Community Health Outcomes. It's a model that was initiated in the US to really just say, if there is no expert on site, can you help those people on site to actually treat the patients with expert advice from elsewhere? It's a teleconferencing technology. When we first heard about it through Jane Carter, who was the then union president, with discussions with NTLD, came up with a plan as to how ECHO can be rolled out.
Project ECHO, their tagline is as a education magnifier, but it's also a very simple approach where you bring healthcare professionals of all types into a virtual room with a specialist to discuss cases and have short didactics. So you're transferring the knowledge of the technical expert to other individuals in the field in a simple way around the questions that they are seeing in their patient care every day.
The main thing which was pressing us as a country was finding the missing cases. Put aside the outcomes, finding the missing cases. So we agreed we will look for our patients. We will not accept anyone to die of TB.
Engagement of pediatricians in TB control activities, and the launch of child-friendly TB medicine in collaboration with TB ARC and TB Alliance is a milestone in childhood TB diagnosis and treatment in Kenya.
Children kind of were left behind a lot in TB control. 10 to 15% of the people with TB will be children. So if you have 100,000 people with TB, 10-15% of those should be children. But we rarely got 10%. We were at 7%, 8% diagnosed with TB. And the biggest challenge with TB in children is diagnosis. Children are not able to produce sputum. When they cough, they swallow. It's hard for you to get that sample for you to go and do a diagnosis.
Among children, through our work with the National TB Program, we have been able to collaborate with even other agencies, other funders, to launch more friendly treatments for children. They would have to take lots of pills to treat their TB, but today it's a more soluble, palatable drug that they can take and actually get cured from TB.
The two drugs were very bitter. So she used to cry, and when she cries, she chokes and vomits. So I had to repeat the dose again, and maybe she vomits again. So it was a struggle.
With the support also from the counties, from the National TB Program, and one of our biggest partners, that is CHS, we were involved in quite a number of trainings and sensitization, especially when it comes to pediatric TB. Diagnosis has always been a challenge. Many of our clinicians at the facilities, they see the children, but when it comes to diagnosing pediatric TB has always been a challenge.
Sasa kwanza kumchukua nikimwacha hivi ndio nikaona alama. Hapa kwenye shingo. Kuna kanini kametokea hivi. Kama titi. Yaani mpupa unainuka juu.
When I heard about Ndulu, if you saw that girl, she was completely deformed with the TB of the spine. Happy Ndulu is doing good. We supported her. She got the corset. She got a bicycle to go to school. Because if that kid goes to school and finish school, one day she will remember somebody helped me about TB.
Nimeonelea hizo ndawa za TB ni sawa, ni nzuri kuliko kwenda kwa waganga.
Because now our TB cases have increased from the previous 7%. Now we are at around 9.1% of our TB patients are children. So we are now beginning to screen.
Corporate engagement through partnerships with Stop TB Partnership Kenya, members of private sector consortiums such as the Federation of Kenya Employers, Swedish Workplace HIV/AIDS Program, International Labour Organization, and the Central Organization of Trade Unions was achieved. They integrated TB workplace programming, awareness, screening, and testing on site in the endeavor of finding the missing TB cases, especially in men of productive age.
Coming in of TB ANC, it became an agenda at that forum to discuss how can we integrate TB with the companies that are our partners.
A meeting of CEOs to just sensitize them on TB. And you see, I guess for most is what's the bottom line, you know, yeah? To just show them, so there was an investment paper done to just show them that investing in ensuring your teams, you can screen for TB, and if there's TB, let it get treated early, will save you a lot of costs in the long run.
Senior management gave me the permission to allow CHS to come into place. Awareness was created, employees were talked to, and thereafter we planned for the testing, we planned for the screening. The few employees who were found to be TB reactive are undergoing treatment.
We have a full-time nurse, a full-time clinic here, and we also impact society. We just don't limit it to the staff here. We have programs where we partner with schools around the community, with centers around here, and also try to get the family members involved in terms of from the employee to go and impact the family back at home.
We have supported public-private mix. It is noted that before a patient comes to a formal health facility, they may have gone to a private informal facility like a herbalist, traditional healers, or chemist to get the relief from the cough.
Mtu alikuja kuniambia ni Violet. Ndiye alikuja kwa nyumba na akanielezea, akaniambia watu wanataka watu wale wanaenda kujifunza kuhusu wale watu wako na TB. Na kweli nilikubali kwa sababu aliniambia wanataka wale watu wanadini na madawa za kienyeji. Nikajua vile mtu anaweza tumia madawa za TB na akwe sawa. Na nikaonekana tena TB kwa upande wa dawa ya kienyeji mtu hawezi tumia na apone, mpaka lazima aende hospitali.
The Inter-County Gene Expert Sample Network transport is key in getting the sample from a distant health center to the nearest gene expert site to reduce the turnaround time for results of the gene expert tests. Depending on the vastness of a given region or the geographical terrain, different modes of private-public transportation were explored, like boat transportation, PSV transport by human transporters, G4S, and boda riders for health, which have proven to be very successful.
We've realized that this has really improved the turnaround time for our samples reaching the central lab and also relaying the results back.
TB-ARC has supported quarterly TB/HIV partner forums, rallied partners to support uptake of isoniazid preventive therapy, conducted sensitization, reporting in DHIS including gene expert and sputum utilization.
Using this program, we've been able to ensure that there are collaborative activities both at national and at the county level. Each of the counties now have a TB/HIV technical working group that meets on a regular basis, identifies all TB/HIV issues, and makes sure that the interventions for both TB and HIV are being coordinated in a collaborative way.
I started off with TB-ARC 3 years ago, and they really used to help, especially with these meetings that I've talked about. They used to consolidate meetings, and they used to support something called quarterly review meetings, where you actually go on the ground, you meet with people at the county. Yeah, you know, now we are devolved system, we don't have provinces anymore. So you meet with people at the county, so you're able to engage both the HIV program and the TB program. So it was quite a collaborative effect, and I want to thank them for that.
So these have been highly successful, they are well attended, and we've seen results from them. For example, we've seen when we wanted to increase gene expert utilization, after 2 quarters we're able to see an increase of gene expert utilization from 40% to 60%.
TB-ARC played a very key role in that. They're the ones who actually used to call people, and so this was a collaborative effect. With government, we cannot take the credit alone. So that is with regards to IPT. So currently we are globally leading with regards to IPT in the world.
So Stop TB Partnership is a membership organization that seeks to ensure that they can they can reach all stakeholders in terms of TB control and ensure advocacy at the highest levels. So it had been formed in 2010, was not too active, especially because they didn't have a dedicated source of funding. So through the TB Act, we supported, and they got 3 permanent staff who've been running the organization.
The Stop TB Partnership Kenya, besides advocacy, our mandate is to create awareness or sensitize about TB in all settings in Kenya, or rather to all the Kenyan population. And how we have approached that is that we have categorized the population in Kenya into 10 settings.
Our secretariat is run by Stop Partnership TB, but we coordinate quite a number of parliament groups, and the big thumbs up goes to Speaker of the National Assembly, Honorable Muturi, who has enabled us to travel and meet some of the expenses through the support of the speakers as the Speaker of the National Assembly. We have been able to move within the continent, and right now as we speak we have the highest number of caucuses, that is country caucuses within the globe. They are based in Africa. TB program had zero budget in Kenya. When I brought up the issue at the Committee of Health, which I also sit in the parliament, we agree that it's not completely acceptable to have a budget.
I'll take an example of one of our very strong advocates by the name Chichi. When Chichi was put on treatment, the government did not have enough drugs for drug-resistant TB because it was a new strain of TB. And by the time he came to be known that he had drug-resistant TB, his health had really deteriorated. After his experience with TB, facing stigma, he chose to become a community healthcare worker. So what he does is that he goes to the community, he looks for people with symptoms, people with a cough. He even talks to crowds, talks to them about TB and tells them, if you feel these symptoms, this is where you can get help. We also take them case by case, and we try to help them to become advocates in that particular area.
Upande wangu advocacy sisi tuifanya kama mimi nimejitolea. Kuna mashirika kadhaa yanajaribu kushirikiana na TB program kueneza, kuongelelea habari ya TB kila pale, lakini sidhani kama imetosha, kwa sababu hili ni jukumu letu sote. Lazima tujiinvolve, tujitokeze na tuiongee kila siku. Isikuwe ati wale wanaofanya Stop TB ati sababu ndo wanafanya na TB ni wao peke yao.
The government was able to write a proposal to Global Fund to support with transport for these drug-resistant TB patients. And a few years later, Global Fund actually accepted to support the TB patient, the MDR TB patients. And to this day, anybody who has drug-resistant TB, they are given an allowance of 6,000 per month to facilitate their travel.
And in 2015 November, I got to win the Cochon Award. Through that award, I have gone to many places to talk about TB. Now I don't shy off. I used the Cochon Award prize, the small amount I got, to support Ndulu. Ndulu will support someone else, and life goes on.
We salute our trained champions who cut across all levels of the society, from members of parliament to healthcare workers and former TB patients in their advocacy activities and use of their influence towards strengthening advocacy activities in reducing the TB burden in Kenya. Our desire to reduce the TB burden goes beyond healthcare to social and economic spheres. And we believe that TB-ARC is a potent social force by itself and is uniquely empowered to make a difference in people's lives in Kenya and finding far-reaching solutions to enriching lives through innovation in healthcare every day.